Welcome back, everyone. My name is Danielle Vaeth. That's spelled D-A-N-I-E-L-L-E, last name V-A-E-T-H. Thank you for the opportunity. I represent Qbtech, a privately held medical device company that has dedicated the last 15 years to providing FDA-cleared, evidence-based tools to improve assessment and treatment monitoring for clinicians dealing with ADHD. I stand here today in alliance with the DEA, ATA, AMA, ABHW, ADA, an ADHD patient advocacy group with more than 6,000 adult members, and many others, for the importance of data-driven and equitable access to telehealth services. We stand that telehealth is health, that mental and behavioral care is health care, and to reiterate Kyle Zepley's comments that all should be regulated on a level playing field, regardless of whether in-person or virtual. We appreciate the opportunity to promote better safeguards for telehealth and in-person visits, particularly when it comes to prescribing medication. I've been at Qbtech for just under a decade and personally have heard from hundreds of clinicians and want to reiterate that the thousands of people, including patient stories, particularly that of later in life adults like Dr. Teddy or Mom Lori, who we've heard from over the last 2 days, are not unique. I must highlight that ADHD access is a public health issue, not just a private one, and was reminded by expert in the field, Dr. Tony Rostein, this morning that none of the science and effort in advancing the field is truly meaningful without access. Based on our experience with over 12,000 clinicians globally, we believe that companies and clinicians should consider adding a level of protection for practices that is not yet widespread in the U.S. Leveraging data better informs treatment and enhances patient outcomes, which includes those receiving care for ADHD, a most treatable behavioral health condition. My aim is to share how prescriptions via telehealth along the care continuum can be considered alongside FDA-cleared objective measurements, ensuring precise dose optimization and mitigating overtreatment. Quality, measurable data that can safeguard virtual prescribing practices is currently available and utilized by thousands of clinicians nationally. By way of introduction, Qbtech, an FDA-cleared medical device, has been available to U.S. practitioners since 2012. It offers a simple and computer-based test that measures hyperactivity, attention, and impulse control. The test can be conducted at home or in a clinic and is interpreted by a trained, qualified health professional. By comparing a highly visual report, incorporating robust data against age and sex controls, clinicians can ensure that the right patients receive the care that they need. The same test is used to measure symptom changes before and after treatment of any kind, often, as we know, with Schedule IIs, to ensure effective symptom improvement. Our experience has been that many patients and parents and clinicians alike lack certainty, confidence, and clarity when it comes to both their diagnosis and decisions around treatment. It is often a misunderstood condition, both over and underdiagnosed. It is a condition that is underserved in medical training programs. For example, 93% of psychiatry residency programs do not include formalized training in ADHD. Ill-prepared to accurately assess these patients, clinicians search for objective data to aid diagnostically as well as to quantitatively measure response to treatment and to better titrate medication dose. I not only represent Qbtech, but the clinicians we partner with, including a clinical and community advocate team, the ADHD Expert Consortium. This group created a call to action statement for increased clarity, advanced education, tools, and resources for which they have almost 900 signatures. Their statement underscores the critical need for data-driven care. The group includes the likes of pediatrician James Wiley in Alabama, who, while educated and resourced on the topic, struggled to find an accurate assessment for his own daughter, who was initially incorrectly diagnosed with a learning disability. These clinicians add objective data to their care pathway because ADHD is a chronic, prevalent condition. It is one of complexity, where management takes nuance. A study by Vaeth Shemelly showed that Qbtech computerized objective data could not only identify treatment response in 84% of patients, but could also separate those with a partial response from those who are non-responders. This is a pivotal moment in our history where we can continue to provide equitable access, evidence-based tools, and safeguards that have been extended in already overburdened system. We believe hybrid models of patient care are necessary, but need to keep in mind that ADHD has a unique burden in this model as a chronic and complex condition with high prevalence rate, treated commonly with Schedule II medications, and that this is a condition which can be missed. Today, we hope to shed light on the role FDA-cleared technologies in ensuring that quality ADHD care can be delivered regardless of the delivery model. Measurement-based tools are providing clinicians with objective data on symptom severity and treatment response, better informing clinical practice, providing accountability, and facilitating safer prescribing practices without the need for an in-person visit. Prescriptions based on data points looking at efficacy as well as time of day help to add safeguards around controlled substance dispensing and to standardize a more stepwise process. Our success extends globally. We have a proven track record in countries that are already prioritizing evidence-based objective data into their pathways. Our testing system is now a standard of care within the National Health Service in England, where 70% of NHS clinics are routinely using Qbtech testing, which after 3 years of study and 70,000 patients, we received a nice appraisal this past March. We now serve over 4,000 clinicians in the U.S. in varying size and geographic locations, from FQHCs and universities to health systems and private networks. We know the need for mental health care virtually has increased since the pandemic. ADHD evaluations and treatment, especially among adults, surged 400% since 2020, while the supply of qualified healthcare providers remains stagnant or sadly decreased. After 5 years of study, Qbtech launched an FDA-cleared remote testing platform, ensuring that quality of ADHD evaluations and medication monitoring remained uncompromised for remote patients. So clinicians like Heather Brannon, a doctor in rural South Carolina, could continue to monitor medication efficacy without compromise just because her patients were receiving care remotely. To date, we have tested more than 70,000 patients using a virtual QbTest. Our robust quantitative data and highly visual reports are incorporated into clinical interview and patient report of symptoms. Qualified healthcare professionals are trained by our master's level mental health clinicians. In 2023, we conducted over 6,500 training episodes in the U.S., ensuring that clinicians are well equipped to interpret and utilize our data effectively. These clinicians all use testing as a part of their assessment process. Additionally, when it comes to initiating a treatment protocol, particularly for Schedule II medications, many clinicians will conduct a repeat testing on treatment to monitor results over time. Depending on the type of treatment and time of day, the clinician may be looking at efficacy, type, dose, class, or consideration of wear-off. This data is then utilized in context of interview and self-report to guide next steps. FDA-cleared objective measurements ensure precise dose optimization and can mitigate overtreatment. Objective data should be recorded at each medication change as available, along with evidence of patient benefit, efficacy, and to mitigate diversion. Many clinicians monitor effectiveness long-term every 6 months to look at changes over time or across the day, both with subjective self-report and objective testing data. Real-world examples and study data similarly confirm the efficacy of Qbtech's objective data in measuring treatment response. A study published in 2022 out of North Carolina, where patients completed a self-report and our testing, were followed up with their clinician at 6 months. When looking at the patient self-report data alone, 36.6% of adults reported improvement. Yet when analyzing their Qbtech results, 85.5% showed a measurable change on their treatment, demonstrating that self-report alone misevaluated over 50% of patients, or 50% of patients were missed with self-report alone when it came to treatment response measuring. Meaning that when employing FDA-validated tools, we're leaving less subjectivity when it comes to measuring if treatments are working. This could lead to clinicians and patients agreeing on changes in dose or medications that were unnecessary. Our data shows that QbTest, when used to monitor treatment response, can distinguish a treatment effect within hours of pharmacological treatment if prescribed a stimulant, meaning clinicians and patients have additional data around treatment decision-making and can further be used for monitoring long-term treatment effect. Pediatrician Dr. Melinda Willingham, a member of our expert consortium who also serves as a representative for the AAP on the Committee for Federal Government Affairs, who uses QbTest to serve an unserved community outside of Atlanta she describes as a care desert, shared this. In today's evolving healthcare landscape, telemedicine presents a unique opportunity to harness rich patient data to advance precision care. By considering data as a vital component in both assessment and treatment response, we empower healthcare providers to tailor interventions with greater accuracy, elevate the standard of care, and ultimately improve patient outcomes. In conclusion, telehealth is healthcare and is providing more people with necessary care. We have the ability to provide equitable and objective approaches to care and ensure accurate screening, monitoring, and clinical confidence, especially in virtual visits, as a safeguard. Together, we can arm clinicians with objective tools and enhance the quality of care for those living with ADHD. I thank you for your attention, and I thank you for your caring. I hope together we can achieve what we've dedicated our lives to doing and making a difference.
Thank you. If I could ask one question, you talked a little bit about, I think you talked about, I just want to make sure I'm tracking and asking you to expand correctly. You talked a little bit, I think, about the guidelines for prescribing, and I think I would love for you to expand a little bit on, are there sufficient prescribing guidelines for ADHD for children, and are there sufficient prescribing guidelines for ADHD for adults?
I think I'll leave that up to the clinical community to comment more. I know that AAP and SDP, the Society for Developmental and Behavioral Pediatrics, have clinical care guidelines around treatment. The adult guidelines are being built right now by APSARD, which is an organization I'm a member of, but I think there is clarity. Mm-hmm.
Sorry about that. Could you just expound on, you said that there was research platform testing of 70,000 patients. Could you,
No,
what was that?
We've tested over 70,000 patients in our virtual platform.
And is there results of that testing? What has it shown?
Those are the number of people who've had access to our testing via virtual. The data, if you have specific questions about the data and treatment response, we've got 15 studies looking at treatment response measurement, varying in terms of length and duration, time from looking at efficacy, time of day, for instance, wear off, those types of things.
Okay, thank you.